So afternoon, everyone. I'm R van Staden. I'm one of the medical officers in orthopedics. And this afternoon's talk will be about, initially I thought the talk would be more just focused on damage control surgery, but I think probably this afternoon I thought to talk about just general management considerations in a polytrauma patient. I think when I started my reading, probably I was quite naive to think that I'd come across a rigid set of rules and principles that would guide you to evidence-based decision-making guidelines for each patient. And the more I read, the more I realized, as we'll come across, each patient is different with a different set of risk factors and different patterns of injuries, which makes and a different management team, which makes them all unique. And I think we're all able to identify the very well and stable patient who we can go all out and manage definitively from the initial get-go versus the patient in extremis. And I think today's talk will be more about raising awareness and some pointers as to identifying a borderline patient where perhaps we need to adopt a new management strategy and where we do no further harm and perhaps delay definitive management. So I think by highlighting certain aspects today of the biological response to trauma, second-hit phenomenon, and bearing in mind that there's been a big amount of research into genetic studies and how many polymorphisms there are and how certain patients just don't follow the certain predictive set of rules, perhaps we'll get a better understanding why and which group of patients are high risk, why certain complications appear at certain times, and why certain patients just tend to do better than others. So we'll cover some advances in trauma care, definition of polytrauma, and we'll talk about the biological response to trauma, trauma scoring systems, and then we'll get to surgical guidelines. I think coming from the orthopedic field, so I'll probably have more of an orthopedic related look to some surgical guidelines, and everyone is welcome to give their input. I think the initial progression, just from how where we've been and how things have moved in relation to polytrauma care, initially in the 1950s, there was the term that the patient was too sick to operate. So a polytrauma patient with femoral shaft fractures was initially deemed too sick to operate, and they were put in a Thomas splint initially and immobilized. And once the physiology improved, the patients were then later operated. And those patients who initially had early stabilization, I think together with advances in antibiotics and improved intensive care and surgical technique, evidence emerged that those patients did much better. And so the new theory was kind of to go big for all these patients early on, and it was their early fixation or early total care. And so that was kind of broadly applied. And as more and more those procedures were done, there was a group of patients which they identified which did not do well. These patients, there was an increased incidence of ARDS and multi-organ failure, which led to this new concept of probably damage limitation or damage control surgery in a patient deemed to be a borderline patient, where we aim to limit the biological load on the multi-injured patient and do no further harm initially than the initial trauma already done. So I think there's been lots of advances. I think of most currently a better understanding of the physiological response, and genetic studies give us a better idea of the physiology and when we can intervene and when to delay. But in general, there's been, the HLS protocols of the orthopedic surgeon stuck or in the helicopter accident, who developed protocols, seem to have developed made a lot of progress. There's been a lot of advances in imaging with regards to bedside sonars, EFARTs. I think in a lot of first world countries, they do a lot of whole body CTs, which has shown, I think I read a study with our number needed to treat was 17 patients and then they identify, for every 17, they identified a reversible, potentially life-threatening injury would have been missed were it not for a CT. Dedicated trauma centers, interventional radiology, damage control surgical principles, and genetic studies have led that for the polytrauma patient, as we'll get to the definition now, with an injury severity score of more than 16. Previously, the mortality rates were in excess of 20%, and we're now moving towards a 10 to 13% mortality rate. So there's been a move from prevention of organ failure and death to a potential restoration of functional status. Previously, the polytrauma was defined as a syndrome of multiple injuries exceeding an injury severity score of 16 with sequential systemic reactions that may lead to dysfunction or failure of remote organs and vital systems that were not initially injured. However, there seems to be, in 2014, a new definition of the presence of at least 2 injuries that are scored 3 or more on the abbreviated injury scale, with one of the following physiological parameters, either having a systolic blood pressure less than 90, a GCS of 8 or less, acidosis, coagulopathy, and age more than 70 included. There's just a table giving roughly an idea of what type of injuries score which grade. We'll get to the scoring systems later. So bearing in mind probably an injury severity score of 16 or more, where those physiological scores make up the definition of a polytrauma patient. So the biological response to trauma, so if we say we're working on a 10 to 13% mortality rate of those class of patients, we see that the most common deaths are in the initial 3 to 6 hour period, where there's medical care just wasn't able to control the hemorrhage. I think that's probably where general surgery team come into play with the damage control, laparotomies and so forth. 6 to 24 hours, traumatic brain injuries, and from there on up to 7 days, we see the complications of sepsis and multi-organ failure. The CRASH-2 study, which looked at polytrauma patients in developing countries, shows that a third of all deaths are due to bleeding, of which 50% die within 10 hours. So the basic response to trauma, which we'll get to in more detail later, is there's this hypodynamic ebb phase they call, where we limit blood loss and maintain perfusion to vital organs, followed by a hyperdynamic flow phase where there's waste removal and nutrient delivery for injury repair, and a recuperation phase where the patient hopefully will return back to baseline, which can be up to several months. So the initial trauma, probably not much we can do about. There's the local cellular responses and the systemic neuroendocrine response, or a SIRS response, which is unavoidable and has relevant complications. I think where we can look to intervene or how we can change our strategies are when it comes to secondary hits, where we perhaps can cause exaggerated inflammation or even immunosuppression. There was always, I think, 2 schools of thought where they had top polytrauma patient. Initially, it sounded they thought the patient would then go into a SIRS response, and only later there was this counter anti-inflammatory response. I think with the latest research, they identified that these 2 responses actually occur simultaneously, and they have a different set of cytokines and cellular responses. So there's the systemic inflammatory response syndrome, which has a purpose and which, when kept in balance, has a good purpose for hemostasis, protection from pathogens, and to initiate soft tissue healing. And where this counter anti-inflammatory response syndrome, or autoimmunosuppression state, is kind of thought to keep the SIRS response in balance. I think with the new genetic input and studies, there's this genetic storm theory, which has shown that there's a magnitude of genes that are either overexpressed or underexpressed, and it happens as soon as 12 hours post-trauma already. And the majority of the genes involved are genes which are actually related to the immune system, and they are generally suppressed. So we have this immunosuppressant type of genetic response to trauma. The initial inflammatory state can be divided into a cellular or a systemic response. The cellular response, we have a local injury, and local response where we have neutrophils, adhesion molecules, and lymphocytes, which when reaches a certain threshold of severity, we have damage associated. They speak of these DAMPs and PAMPs, damage associated molecular patterns, which ultimately stimulate an inflammatory cytokine response, which can herald a cytokine storm, and that's when we see the SIRS response with early stage complications or organ dysfunction, and it's characterized by general SIRS parameters as fever, capillary leaking, vasodilation, when the neutrophils that have been localized to the injury, when perhaps when the response is so severe, they lose their autoregulation, and we have to see that there's toxic release, which leads to remote organ damage. Of the systemic response, it's been a lot of research looking into biomarkers, of which I think interleukin-6 seems to have been the most biomarker, which gives us a predictive value of adverse outcomes. And when you have a polytrauma patient in the ICU or in a high care, they've shown that a SOFA score increase of 2 or more leads to up to a 10% increase in hospital mortality, so can be quite significant. I think bearing this all in mind, this hyperinflammatory response, which leads to capillary leaking and leads to potential pulmonary edema, also has, probably more for the orthopedic team, has local or has implications on your wounds, where you see endothelial dysfunction and interstitial fluid loss. So there's decreased oxygen transport to the wounds, there's increase in edema in extremities, which probably can further compound soft tissue injuries. The anti-inflammatory state, or this CARS, counter anti-inflammatory response syndrome, is, like I've said, seems to not be the cessation of SIRS, but rather a deactivation of the immune response, where there's decreased lymphocyte proliferation, decreased cytokine production once the lymphocytes have been stimulated, and increase in expression of certain cytokines like interleukin 10, which has a suppressive effect on tumor necrosis factor, which is an inflammatory cytokine. So this anti-inflammatory response is characterized by hypothermia, a low white cell count, susceptibility to infection, and this inability to clear infections. And I think some of the research into biomarkers giving us a guide as to when this patient is in this autoimmunosuppressant state. I think the most significant studies show that you can look at a ratio between interleukin 10 to tumor necrosis factor, which has proven an increased which has proven a correlation to mortality. This is just a graph to show you of, I think on the left-hand side, you see the picture of the solid line is the patient which initially involved in the trauma as the SIRS response, and the later the CARS response. And that response seemed to have been kept in balance, so there was no significant complications of sepsis or anything else. But as you can see, the dotted line represents the patient with a complicated outcome, where there seems to have been this exaggerated response for whichever reason it may be, whether it was just a patient who is genetically prone, or just a very significant trauma, or, for example, when there was a second hit, like a diagnostic or surgical procedure performed. So the second hit phenomenon, probably the parts where us as a surgical team or a management team, not necessarily just surgical team, but a medical team doing diagnostic procedures, are involved and can probably work on our strategies, but it's a biochemical or physiological alterations due to surgery or procedures post-trauma. It's an additional inflammatory hit to an already primed endothelium, which has shown to increase progression to acute respiratory distress syndrome. I think that's a graph which I've got from one of the orthopedic handbooks, looking at elastase as an inflammatory marker, where you can see that acute spike is just shortly after, I think 1 hour after intramedullary nailing, showing the SIRS response to an intramedullary nail. So scoring systems, for myself, I thought a scoring system would be able to give you a direct idea as to, yes, this patient is ready for surgery, or this patient is not. It seems to be actually quite unhelpful, but good to know. It's a common language, which the aim is to convert multiple independent factors into a single numeric value representative of the degree of critical illness. So the ideal score looks at the anatomy, how severe are the injuries, the physiological response, inherent patient reserves, the age of the patients, any relevant comorbids, and they ideally would keep in mind immunologic and genetic predispositions. So the purpose of scoring systems actually more as a triage tool, or to predict outcomes and hospital stay, or used for risk of disability assessment and reimbursement purposes, or as a research tool. The common anatomical scoring system that we use are probably the injury severity scale, which we'll get to now. And then there are physiological scores, the trauma score, the revised trauma scores, and combination of these, the TRIS score, the trauma and injury severity score, which probably gives a more well-rounded idea of the patient's degree of critical illness. So the injury severity scale looks at 9 regions: head, face, neck, thorax, the abdomen and pelvic contents, the spine, the extremities, and the external. And basically you look at the sum of the square of the 3 highest scoring regions, with the lowest score being 1 and the maximum being 75. If you have a region that scores a 6, you automatically score a 75. So the scores seem to be a good triage tool and a good predictor of mortality, except if you had only a single area that was severely injured, and so thus the score has been modified to a modified injury severity score, where you can take the sum of the 3 highest scores regardless of the area. So if it were just in a single area, you don't actually only have to use only the highest score, but you can use your 3 highest scores. Roughly, just to give you an idea, so there's a patient in the ICU high care now, Mr. Prinsloo, with the facial fractures, the bilateral rib fractures, and I think pneumothoraces with the scapular fractures. So if you look at him, he probably has a facial fracture which scores a 2 or I said 3. He's got multiple rib fractures, so a 3, and he's got a scapular fracture. I looked up, scores a 2. So his ISS score would be 22. So he would count as a polytrauma patient. Oh, and the liver rupture as well. So even more. Yeah, so plus another 25. So then his scores are 47. Yeah. Yeah. Okay, well, nonetheless, so he's quite a significantly injured polytrauma patient. I think so. When it comes to surgical guidelines, as I mentioned in the beginning, ideally we'd all like to treat all our patients definitively from the beginning. Those patients just seem to have, or not seem to, it's been proven they have better pain control, their nursing is better, they rehab better, they have shorter hospital stays, and their outcomes are better. However, it's not appropriate to treat this group that we'll get to now, the borderline, unstable, or extremist patients, where probably we have to aim our efforts at resuscitation to restore the best physiology possible, and then get to definitive surgery later. So there's on the pendulums on the left-hand side, you see early total care for the stable patient, but in the middle, early appropriate care, where maybe you have staged surgical procedures, or on the right-hand side, damage control, orthopedics or damage control surgery. I think on the bottom left, the role of the orthopedic team is probably in terms of hemorrhage control in polytrauma. If you've got long bone fractures, to prevent contamination as a sepsis source, pain relief to relieve ischemic reperfusion injuries, compartment syndromes, or to facilitate nursing, ventilation, or rehab, where I think the lethal triad we're well aware of is catastrophic in the polytrauma patient. The hypothermia, whether it be from environmental exposure, impaired thermoregulation due to intoxication or traumatic brain injuries, or if you have open cavities, where acidosis may be due to prolonged hypertension or certain fluid resus and contributes to worsening coagulopathy. So bearing that all in mind, from a reading, I've come across this kind of algorithm which can give us a guide, and we'll get into physiological scores a bit later on as to what makes up a stable or a borderline patient or unstable patient. But roughly, if you can have a polytrauma patient classified into either stable, borderline, unstable, extremist, there's a bit of a guide. So a stable patient, we say we can go for early total care. We can do definitive management and give them the benefits of early total care. Patients are hemodynamically stable, they're not on inotropes, no hypoxia, hypocapnia, the lactate is less than 2, and they've got a good urine output. If you think of a patient who you're not 100% sure of, they're not 100% stable, but they're also not unstable, perhaps there's something easily reversible, hemorrhage or a pneumothorax or something like that, or something you can identify on a blood gas which you can reverse. You can differentiate your patient from being borderline into stable, where you can treat them definitively early on, or if you're uncertain, or if you have the resources and you can look at certain biomarkers, you can classify them as unstable or a borderline patient not yet ready for definitive surgery, and then we look at damage control principles. So I think probably this is the most important slide, or for someone who's not that experienced, for us as juniors, probably the seniors can see a patient and take into account the different injuries and immediately make an assessment as to what the patient is ready for now or not. But if you are able to table something, I think this is a good slide. So the borderline patient, they say, is where you have at least 2 of the following criteria. You have multiple injuries with the injury severity score of more than 20 with thoracic injuries, or multiple injuries and pelvic and abdominal trauma and an element of shock. The injury severity score of more than 40. Radiological evidence of pulmonary contusions, an initial platelet count of less than 95, initial temperature of less than 35, a PF ratio of less than 200. If you are able to measure pulmonary artery pressures more than 24, an increase in pulmonary artery pressures during intramedullary nailing, interleukin-6 levels, and some authors even mention bilateral femoral shaft fractures as potentially being a borderline patient. So patient selection for damage control surgery, which of the following parameters: a lactate more than 4 or a pH less than 7.2, systolic blood pressure is less than 70, a transfusion approaching up to 15 units, quite significant. They suggest we use damage control principles. That's probably this unstable in extremis patient. This is quite an extensive table. I don't think one can remember much about it, but it's in the AO Advanced Orthopedics book, and they look at parameters of shock, coagulation, temperature, and the degree of soft tissue injury, and they've tabulated multiple physiological parameters and helps you to classify a patient into a certain group. And then I think, bearing in mind the SIRS response, as well as the counter anti-inflammatory response syndrome, I think this table gives you a good idea as to windows for potential definitive surgery or danger periods. So initially, day one, if you have to perform a life-saving surgery, like we said, that initial six hours or hemorrhage control is essential. Then perhaps you have a patient that has transiently responded to your initial fluid resus or blood products. You might only go for damage control or life-saving surgery, as we mentioned. Day 2 to 3 seems to be marked by this hyperinflammatory state, where the suggestion is to do only a secondary look, no major surgery. Day 4 to 10 seems to be a safe window of opportunity where we can perform definitive surgery. Day 11 to 21, so up to 3 weeks, ideal to avoid surgery, and after 3 weeks, return back to normal physiology. So I've got some articles here that we've looked at, which are orthopedic related, but basically this article looked at secondary phenomenon and the existing evidence of clinical implications. So they looked at polytrauma patients with concomitant chest injuries, and they looked at early versus late femoral shaft fixation, where early was mostly described as within 24 hours. Some articles included early being up to 48 hours. But interesting to find that timing of surgery was more significant predictor of potential complications than the type of surgery. So whether it be a reamed femoral nail, an unreamed femoral nail, a femoral plate, it was more about the timing rather than the type. In hemodynamically stable patients, there was no reservations about reamed femoral nailing. Complications of polytrauma patient with chest injuries were more directly related to the chest injury and not necessarily the method of fixation. They agree that the time frame for avoidance is day 2 to 5 post-injury. Acute respiratory distress syndrome was 4 to 5 times more prevalent if you perhaps had to delay your initial fixation. So the patients who were fixed late, so after 48 hours, seem to have more complications. The higher the injury severity score, the more significant the benefits were of early fracture stabilization. Early, whether you did a reamed femoral nail, an unreamed femoral nail, or a plate fixation, seemed to have similar ARDS prevalence. There was no significant length of hospital stay difference between the different ways of femoral fixation. However, late fixation showed a 2 to 3-fold longer ICU stay.
So your time frame for avoidance, you meaning if you can go and do surgery, then day 2 to 5.
Yeah, so yeah, like that table shows. So day 2 to 3, this table says, that article says day 2 to 5. It seems the patient's in this inflammatory cytokine storm and you're at risk of complications. So that same article looked at certain clinical conditions like fat embolism or pulmonary embolism. This is the same polytrauma patient with a chest injury. It seems that there was no evidence to correlate fat embolism or pulmonary embolism to timing of surgery, although it shows that you have increased embolic loads when you do femoral nailing later, more than 48 hours post the injury, or you perhaps reaming a pathological fracture. early plating versus nailing had no pulmonary embolism difference. The operative treatment seems to show a decrease in fat embolism incidence than those treated conservatively. In terms of cardiopulmonary function, via pulmonary artery pressure monitoring, we know that at guide wire insertion and reaming of the femoral shaft, there's an increase in pulmonary artery pressure. I think of interesting in terms of coagulation, it showed that early reamed femoral nailing significantly decreased your platelet counts within the first 2 days post-op, where unreamed femoral nailing had no platelet impact. Late, so more than 48 hours post-injury nailing, significantly lowered platelets and fibrinogen than early nailing. And what did I want to say here? So inflammatory cytokines were all up with reamed versus unreamed femoral nailing. And I think, so the interleukin-6 level of a rise in an early unreamed femoral nailing was still higher compared to a X-fix and a later unreamed femoral nail. This study looking at the timing of orthopedic surgery in multiple trauma patients and the development of protocol for early appropriate care. So in this study, they looked at which clinical conditions warrant a delay of a pelvic femur acetabulum or spinal surgery. So in which of these patients should you avoid in early surgery? And I think they were looking mostly at the physiological status measured by acidosis. They thought that measuring your initial acidosis could give you a predictor as to delaying surgery, because you might be at risk of complications. So they once again found that benefits of early stabilization were more profound in the multiply injured patient versus a patient with only an isolated injury. The presence of a chest injury was the greatest predictor of a pneumonia, not necessarily the method of fixation of long bone fractures. And I think they suggested that your resuscitation effort should within 8 hours improve your initial pH. If you could improve your pH to more than 7.2 or a base excess of less than 5.5, you probably have decreased respiratory complications. I think we've kind of covered this. Long bone fracture stabilization, improved pain management, decreased pulmonary complications, and decreased soft tissue injuries, and improved wound healing. This is just related to the study looked at pelvic stabilization, and basically mentions that I think part of the resuscitation effort initially is to stabilize an unstable pelvic ring fracture. Interesting to me was that angiographic embolization, so interventional radiology, doesn't really have a place in the acutely unstable patient, possibly only later on once in a stable patient. And they have shown that early pelvic stabilization decreases blood loss and decreases blood transfusion requirements. Since we've covered this, and those are my references.